everyone is getting me right. So before I go into explain the urinary system, I'm going to move to the special population. So let's talk about special population. Now, the reason for this topic is that America is a diverse population country. I know other countries have several different populations mixed with them. But America, since everybody wants to be in America, America does have a lot of different people you will meet. And those people you'll be taken care of. So regardless of whoever the person is that comes your way, you have to take care of the patients. So if I am Black, if I am red, if I am yellow person, you are still obligated to care for me. There is no need for selection. But besides that, we have people that are of selected populations that they have eyes on. And you and I may not be part of that population apart from our ethnic backgrounds, apart from the fact that you are from you are a Haitian, an African, apart from those considerations. So now I'm just going to be a little quick on this one because I want to start at least to discuss the anatomy of the kidney and the tests that should be done when a patient has kidney problems, so that next time we'll jump into the diseases, or if we can today, it will be fine. It's not too tedious, it's not too much, but I do wish you a good understanding of this. So special population groups, the literature identify numerous groups that may be designated as a special population group. For this chapter, there are several people that are considered special population. We have the vulnerable groups, and they typically experience health disparities and inequalities. And this include people of color, those who are uninsured, those who don't have insurance, those living in poverty, or homeless people, those with chronic illness, disability, immigrants, those who are immigrants with issues, refugees, those with limited English, those who are incarcerated, and members of the LGBT, if you bear with me. And then looking at these people, they have a categorized group that they are considered part of the special population. So as a nurse taking the NCLEX, you need to understand what is specific with this group of people. What do you do if a patient comes to you and is an LGBT and you are a Jehovah Witness? Do you dodge the patient? Do you ignore the patient need? If the patient is a woman and comes to tell you, I want to be identified as a male on the NCLEX, you have to obey whatever they say. You have to treat them as a woman. So that's the special population we are talking about. And regardless of your religion, regardless of where you belong, if you are going to be a nurse, you'll be faced with these people. You have the homeless people coming to beg for food at all times. So healthcare providers, you have to be aware of yourself. That's what I just finished. You should know your own culture, where you come from, your values, your beliefs. We have some providers that have basically said they will not do any abortion because of my religious belief. You should have a documentation and you should be covered to do that. But NCLEX does not allow you these options to choose your religious beliefs. You just want to get the license and get out of the way. So some of those things come with practical and facility standard basis. So you recognize your own biases or prejudice and being respectful to all these group of people. That's what you are entitled to do. If you understand that my belief is African American, my country, we don't believe in this practice, but I am here, I have to take care of the patient. That is what the population or the society in America is giving us. An encounter with a client should elicit the client's unique perspective based on their cultural preference, because it will allow the nurse to understand what healthcare treatment will be realistic and acceptable. So if you don't accept the person because the person is a homeless, the person come in smelling and all that, skin is not kept, If you don't accept the person, you'll not be able to talk to the people and they wouldn't give you information. So NCLEX does want you to be part of the care of this group of people. Now let's talk about racial and ethnic minorities. Due to the increasing diversity of the United States population, minorities are projected to become the majority. Racial and ethnic minorities are affected more often than their white counterparts by healthcare disparities and inequalities. Social determinants of health are conditions in which persons are born, grow, live, work, and age, including healthcare system, and are correlated with health and health inequalities. So you are born, bred, you grew up in America, but because you are Black, your color does give you a limitation on certain areas you can fit. That's the belief and the racial disparity they are describing. Now, cultural competence is a necessary ability for healthcare professionals to provide care for a diverse population and can help improve health outcomes and the quality of care. So cultural competence, you have to be culturally competent to withstand the cultural difference of other patients. So you return explanation and demonstration of a teach-back setting. And these are particularly important when working with clients of various backgrounds. So you understand me if I am from India and I come in and I cannot speak the language, you accept me as I am. So I remember that question I gave in the 15 questions, everybody was able to answer it right by choosing the use of medical translator system. That is what is specifically recommended in America. Gertrude, I know in your practice setting, you may not have those kind of things, but get this right, that in America, everybody, when you come in and you cannot speak your language, they have to get a medical translation system. You cannot manage the language, you cannot speak well. So some ethnic minorities report hesitancy in seeking healthcare due to language barriers, ineffective communication between the healthcare provider and the client, and can affect client safety or client's ability to comply with follow-up care. So if the discharge planning or the discharge information was not appropriately given to the patient in the language the patient understands, the patient gets home and does not even know if I'm supposed to follow back with the provider. Now, description and population-based risk factors. So we have African American. So this section talks about what is specific about this group of people, about the cultural and ethnic backgrounds of people. So African American is a population, this population, they have an origin from the African and the Caribbean. So that's the Blacks in general, if I would say. So they have nearly 50% of adults with chronic health conditions. So African Americans have about 50% of adults with chronic health conditions. Now, these conditions could be hypertension, diabetes, mellitus, heart disease, asthma, cancer, and these are the most prevalent in this population. So African Americans are prone to high blood pressure, diabetes, obesity, and asthma and cancer. Even everyone is at risk for cancer. So when you look at the number of patients that present to you with cancer or the number of patients that present to you with hypertension, especially, you have a greater proportion of them count as African Americans. So this is what they are saying. It doesn't mean if you are from an Indian descent, you don't get hypertension, you do get it, but this population is considered higher risk than others for that. Hispanic. So these people are the Mexicans, the Puerto Ricans, the Cubans, Americans, the Central American, and the South American people. So this population too, they may not have health insurance. That's the Spanish people mostly. So the population, they must avoid stereotyping to ensure the delivery of cultural competence to optimize healthcare outcomes. So some in this population may not also have health insurance, like I said before, or a regular source of health care. They may not have a regular healthcare provider. They just walk in every time I am sick. I don't go to a particular doctor every time I am sick. I just walk into the nearby hospital, or I just walk in wherever I want because I don't have a specific provider. It's a culturally considered thing. So that's what they want to do. So they also have a health risk. Their adults have 35% of chronic illness. So in as much as African American adults have 50%, the Hispanics, they have 35%. They are adults. They have 35% of chronic health problems. So they can have obesity, diabetes, and end-stage renal. So end-stage renal are mostly people who go on dialysis. So when you happen to have been in a dialysis unit and you count the number of Hispanics that come there with kidney failure and needing dialysis, you see that they dominate. So this is also their risk. So anybody can get it. Anybody can get chronic kidney disease, but these people, they do have that too as well. So some leading cause of death are heart disease, cancer, and accidents. So as why they have a leading cause of accidents, I cannot tell, but get it right. That is specific to Hispanics. Other health topics include, but are not limited to, discuss surrounding diets and meal plan and exercise and safe sex practices. So this is their surroundings. If you want to educate a Hispanic male or a Hispanic young female, you educate them regarding their diet. They should not eat too much, eat anything, eat from every store, because this population mostly buy food from outside, or they eat a lot from outside than they do cooking in the house. This is cultural specific, and that's what the book is saying. I'm not the one formulating this, the cultural specificity of these people. So you teach them how to do exercise. If they eat a lot of those food, they do exercise, and then they practice safe sex. Now we have the native Hawaiian or the other Pacific islanders. So this population has origin in the Pacific Islands, including Polynesia, Micronesia, and Melanesia. That's the countries, the areas they are coming from. So this population, they are noted to have higher rates of smoking, alcohol consumption, obesity, and diabetes. So far for all these populations we have discussed, they all have a risk of diabetes, obesity. They all have that in common. So when they are presenting to you with a patient and they mention any of that, unless it's a specific difference they want you to make, then you try to identify the cultural specificity of that person, because it's like almost every culture will have obesity, diabetes, but lifestyle does matters to some of them. So these people have a problem with smoking and alcohol use, in as much as we see everybody use alcohol. So there's a high incidence of infant mortality and sudden death syndrome in this population as well. So the native Hawaiians have a high incidence of sudden infant death syndrome. Sudden infant death syndrome is when the child dies before, I think, 2 years or so. Yeah, I think it's 1 year, the first year of the life of the child. So mostly they relate it to the shaken baby syndrome that causes the sudden infant death syndrome, or other problems that will lead to the sudden infant death syndrome. So they have a problem with that. So let's talk about American Indians and Alaska natives. So this population has their origin in Central and South America, and they have a tribal or community attachment. If you know these American Indians and the Alaskan natives, they like to live in clusters. They like to live in groups. So you come to my area and one area is all made up of Indians. They live. So for instance, in the Bronx where I work, the area is made up of mostly Bengali people. That's the people from the Indian descent. So that area is specifically their area. When you roam around that area, you see majority of them. So when you do a statistics of that area, I had conducted a research for that particular area, and the population that the Bengali people occupy in that area was very high. They had like, I think 60 or 75% of the Norwood Bronx population. So it's a research that I did for that particular area. So they have a greater number they live in clusters. So the American Indians live in clusters, in groups. So cultural barriers, geographic isolation, and low income prevent this population from receiving quality health care. So they don't want to receive care because of these problems. Cultural barriers, sometimes they cannot speak the language. Geographic isolation, because they believe in being isolated. So if I'm going to the hospital and there's no Indian doctor, I don't want to go. So they have they do have a risk of not going. So some leading cause of death among this population can be heart disease, cancer, malignant neoplasm, cerebrovascular accident, that's CVA, and car accident as well. So this population is at high risk for altered mental health, suicide, sudden infant death syndrome, teenage pregnancy, liver disease, and hepatitis. This is a high incidence of infant, there's a high incidence of infant mortality in this population as well. Now let's talk about Asian America. This population has origin in Southeast Eurasia, Southeast Asia, or the Indian subcontinent. The population is disproportionately noted to have different types of cancer, tuberculosis, hepatitis. That's the Asian Americans. That's those from the Filipino side. So they are the Asian Americans. That's the Filipino area. So some leading cause of death among these people are cancer, heart disease, and stroke. So some older Asian Americans women are at increased risk for suicide as well. So healthcare consideration for racial and ethnic minorities. I talked about cultural competence and cultural awareness. That has to do with you, the one dealing with the patient. You have to be culturally competent. You have to be able to meet the demands of other culture, people from other culture, and you have to be aware of your own biases, that you don't go selecting only African Americans if you're an African American. We have some people that cannot deal with that. NCLEX want you to note that you have to take care of all of them. So when they are presenting questions from this section on the NCLEX, they are going to present to you as a patient from the Asian descent, and present to you with questions about their reproductive system. They want you to know whether this person will receive care or the person will not want to receive care. So if I am from the Indian descent and the doctor that's giving me care is a male and I'm a female, I can decide to say no. And also this group of people, they have a situation where the man will not allow the woman to talk. The man is the one that makes decisions for his wife. So women are not allowed to talk in this population. They are not allowed to be able to verbalize their healthcare problems. So when they come together, unless it's only the woman who presents to you, but when they come together, it's the man who dominates everything. And that's culturally accepted. So that's who they are. Unfortunately, knowledge of the various racial and ethnic groups in terms of cultural preference, health risk, and health preferences is needed to deliver culturally competent care. We have the lesbian, gay, bisexual, transgender, and queer, or questioning individuals. The queer are those who are not sure. I'm not a man, I'm not a woman, they are queer. So commonly referred to as the LGBT community. This group is represented by a worldwide range of varying characteristics in terms of race, ethnic, age, socioeconomic status, and identification. Unfortunately, stigma and discrimination is a reason for their identification. Special population. So they added them as a special population because of the stigma they face, and they don't want to always disclose themselves, even though lately the right and other stuff is making them open up, but they have a discriminatory effect. So because of that, they are considered a special population. So sexual orientation, I'm not going to talk about that. So this one, the term sexual orientation is an encompassing term used to describe a person's behavior, identity, and desire. A variety of words may be used to describe sexual orientation, including men who have sex with men. So sexual orientation is if I am a woman and I decide that I want to be a man. That's my sexual orientation. So if you ask me, I'll tell you, I only want to have sex with men. I don't with women. I don't want to go to a man. That's it about the sexual orientation. And it's the same explanation. That's the opposite of what I just explained. So the term transgender is used to describe individuals who do not identify as a person with their birth sex. Transgender. So you don't describe me with my birth sex. I was born a female, but you describe me as a male. That's a transgender. Important research is needed with regards to the healthcare needs of various gender identities. So in general, for the LGBT, they have a lot of research that has already been done. And they came up with the fact that stigma was their #1 problem. So they added them as a special population. But besides that, the other part of it is the lesbians, gay, bisexual, queer, homosexual. They're trying to get a lot of researchers from different names that has been attached to them. So the risk factors for this population, some of the LGBT persons may be less likely to access healthcare than other populations. So if I come out right now and I put myself like a man accessing healthcare, I may not want Clementina to see me. So I have a challenge going to the hospital because I know Clementina, if she sees me and I'm dressed like a man, it might look embarrassing. So because of that, they don't like receiving healthcare. So that's a risk factor to them. There are no health disparity specifically associated with this population as a group. However, there are members within this population who experience inequality in healthcare management, which are due to a variety of other factors. So this inequality in healthcare management is just about getting leadership in healthcare or occupying a leadership position and not being the right gender from birth. So I'm going to move straight to this point, this yellow highlight here. So one thing I want to let you know is that because everything is becoming popularly known and well recognized, you may get questions from these sections because the LGBT, you need to know what is specific about them. Their main problem is stigma, and they can decide not to access healthcare. They are afraid, they are scared to move around, but don't go answering questions that says that you have to analyze the question and see what it is directing you to. But just take note that they are prone to stigma in some communities, especially areas that it has not been legalized. So the healthcare considerations for the population, healthcare professionals need to create a welcoming, non-judgmental environment when caring for this population. Measures such as altering signage or paperwork, such as document asking for gender identification, will better serve the healthcare needs of this population. So when they come to you, that's why right now, when you look at all documentations in all facilities, they have a section that wants you to identify if this person is a male or a female. So if I see you as a female and you tell me you are a male, I am supposed to document as a male. And that is what everybody uses. So if anybody is not sure if this person actually is a male, you have to go to the patient and ask the patient, how do you want me to identify you? So this is how NCLEX is going to present to you. They want you to know the approach you give them. So you want to ask, how do you want me to identify you, male, female? You give them the options and let them choose. So the person is a female and says, I'm a male. You don't ask, are you sure you are a male? No. So just accept them the way they say. So we have training to work respectfully with the LGBT population should be provided for all healthcare personnel. So facilities are now giving in services on them. They are training everybody to be able to work with them. If your coworker is one of them, it's not your business. You accept her or him. Use of open-ended questions and refraining from asking judgmental client questions during client encounters are important. That's what I just said. If you say I'm a female, don't go and ask, are you sure? Are you really a female? Are you this? Are you that? So you have to be careful. You have to refrain from that. Additional screening in this population should include HIV testing. So this is actually the area I wanted to talk about. They are prone to STIs. So when you are screening them, when I finish this point, I'm done with them. So when you are screening a patient with who is and from the LGBT community, you want to ask them if they want to have an HIV testing, or you want to find out of their HIV status. You want to ask them of other STIs, sexually transmitted infections, is a problem with this group of people. So you want to ask that. But remember, the book says you have to also do it respectfully. Don't be judgmental in your questioning. So mind you, hepatitis A, hepatitis B, HIV, chlamydia, gonorrhea, you are going to ask this population about those things if they want it to be done. So that's the most specific thing that I wanted to come about, the stigma part, and then the testing aspect to be aware of. Now, the homeless people, they are considered a special population as well. So this affects men, women, everybody can be a homeless person of all racial and ethnic backgrounds. Family units can be affected as a whole. So we know about the homeless people who do not have places to live and they're hanging around. What are the risk factors? What makes a person a homeless person? So the risk factors is early death related to chronic illness, substance abuse, environmental exposure, communicable diseases, cardiovascular and respiratory disorders, skin disorders, and mental illness. So these are the things that put a person at risk for being a homeless. Nearly half of this population experience mental illness issues and coexist substance use disorders. So malnutrition and poor dentition are common. So malnutrition, they are malnourished because they don't get enough food to eat. Poor dental hygiene or poor oral hygiene is a problem. Disability often results from illness because they're hanging around in the street. When you look at the weather in here, it's too bad to have them on the street day and night. So because they have no place that they are living, they are prone to disabilities due to illness related, and they also have a barrier to employment. And this one is also a problem for the homeless. It's a risk. So if you are at risk, if you don't have a job, you have some kind of illness that is stigmatized, you cannot have a place to live, no financial support, no family support, you end up homeless on the street. So that's the risk factors. Infants affected by homeless often have low birth weight. So if the homeless person that is hanging on the street it gets pregnant and gives birth to the child, mostly the problem with the baby will be low birth weight, because imagine you're hanging on the street, you don't get enough care. They may not even go for health care. They may not even go for checkups, so they don't know what is going on. And they may not even know the father of the baby. So the children that are affected with the homeless are sick, more often with illness such as asthma. They get asthma, iron deficiency, lead poisoning, ear infections, gastrointestinal illness, and mental health and behavioral health problems. Now, let me jump to the lead poisoning aspect. So lead poisoning is mostly a problem with pediatrics. So the NCLEX like to talk about lead poisoning as well. It's a problem with pediatrics. It has to do with the child getting in contact with lead stuff, and you see shortness of breath. So take notice of lead poisoning in children. That also goes to poison control. So when you are managing a pediatric or a mother present to you that my child is this and my child took something, some 3 pills, or I had 4 pills in this bottle and then I came back, I didn't find it, and my child is holding the bottle, is open, then you want to direct them to call the poison control. There's basically, you usually don't have any serious management at that point. You need to let the mother call poison control. So poison control management in pediatrics, be aware on the NCLEX, they like to dig into that. So you have to always, if you are the nurse, your education to mothers should be that they need to have poison control numbers readily available. So if they suspect the child have taken some substance that is they are not even sure about, the best is to call poison control. Okay?
Yeah.
So let's move to, I was talking about the risk factors. So I spoke about this one, Children may begin to act out or become less attentive in the classroom when basic needs are not met. Youth experience health problems related to risk-taking behaviors such as alcohol abuse, depression, suicidal attempts, unintentional pregnancy, and sexually transmitted infection. So these are all the risk factors for the homeless people. So women experiencing the high rate of unintentional pregnancies and physical and sexual abuse. I said that before. So healthcare considerations for the homeless. You identify those who are homeless with and should be done through avenues such as outreach programs. So they organize an outreach programs, the NCLEX, if they ask you, they should be recognized people who are homeless through outreach programs to identify them. The initial healthcare visit and every visit thereafter needs to be done with a non-judgmental, threatening approach. So you don't threaten me because I'm a homeless person. You treat me just like you treat every other patient. So when you are taking care of a patient that have approached you and say, I don't have a house, I'm a homeless person, you, the nurse, you are not supposed to send them away because of health insurance issue. You are supposed to refer them to community resource services and have them follow up with them. So subsequent care should include healthcare maintenance, attention to social problems. You need to understand their problems. You need to understand them, why they are homeless. So I put this yellow thing here for you to take a note that homeless people often experience poor nutrition, sleep deprivation, violence, physical trauma, emotional trauma, and long-term exposure to toxic agents. They can also go into drug use, which is also a big deal. Drug and alcohol use is also a big problem with this group. So the homeless individuals may not adhere to medical treatment. They may not follow up with their doctor. They only come when they need food. This population tends to lack health insurance, and they have longer hospital stays and have poorer health outcomes. So their health outcome is poor because even if you sustain them, if you give them the necessary care they need and they go back, they still go back to this cold weather, to this homeless state, and they wouldn't have enough to feed themselves. So they turn back and then they return. So some of them does stay longer in the hospital, and some don't even want to be discharged. They become hospital property. Certain medications should be avoided in this population due to potential for serious interactions with alcohol and recreational drugs. So like I mentioned before, the homeless people use a lot of drugs. Some of them tend to become drug addicts. So you have to avoid certain medications they take. The potential, I have some of the medications written down somewhere. So I will read them out to you in a little bit. So the risk for dehydration, contraindication, chronic conditions. Now let's talk about the common problems in the homeless population. Their problem is anxiety. They have bipolar disorders, cognitive disorders, communicable diseases. So you look at scabies, most of them will come to hospital with scabies. Most of them will come with, what's the name? Shingles. Most of them will come with eczema, communicable diseases. They have a problem with that because they're hanging in there. They don't even know who they get in contact. They see everything, they pick it and put it on themselves. So they're at risk for communicable disease. Complications for poor hygiene, either oral or general hygiene, bathing, they don't usually do that. If you have seen them before, you will know what I'm talking about. Poor living conditions, prolonged sun exposure, and prolonged standing. Coronary artery disease, dental problems, diabetes, mellitus, domestic violence, and rape. Frostbite. Now, this is what they will use to bother you. They like to dig into frostbite. Read about frostbite. Heart failure, heat exhaustion, hyperlipidemia, hypertension, injury from violence, lice, scabies. If you have ever seen lice, you have seen scabies and bacterial infections, you know what I'm talking about. Ringworms and all those things. Schizophrenia, sexually transmitted infections, skin and foot conditions, substance abuse, suicide, traumatic brain injury, unintentional pregnancy. So most of the homeless people will present to you and they come in and some of them are even knocked out. Mostly they give them Narcan. You have to give them Narcan 0.4 milligram to revive them. Narcan is an opioid antidote. So if a patient overdose opioids and they are knocked out, they come in unconscious, you give them Narcan. You can give it up to, the maximum you can give is up to 10 milligrams, but it's 0.4 milligram at a time. So you wait 2 to 3 minutes before you give a next dose if the patient don't wake up. So they give them Narcan, but while you are giving the patient the Narcan, you look for other means or other causes of the patient unconsciousness. So it may not be opioid overdose, maybe something else they need. So the medications that you should avoid in this population is albuterol. Albuterol is asthma medications. I had spoken about it. It's a bronchodilator. Benzodiazepines, beta blockers, atenolol, metoprolol, you avoid those medications. We have bupropion. This is, I think this one is depression, right? Yeah. So bupropion is antidepressant. Yeah, it's depression medication. Calcium channel blockers like lisinopril, captopril, and all those things. You want to tell them to stop it. Clonidine, non-steroidal anti-inflammatory, that's ibuprofen, Toradol, quatipine, and then some diabetic medication, particularly sulfonylureas, those oral diabetic medications. So you try as much as possible. Listen, another thing I want to state to you is that if you have been to the health field before and you see homeless people come in with a bottle of medications and they tell you this medication is metformin, this medication is metoprolol, this one is lisinopril, this one is this and that. The book says you are supposed to, they are supposed to avoid those medications. Don't go contrary to answering that the patient can have it. You can't answer that. They are supposed to be contraindicated due to their poor living conditions and their risk for medication overdose. So they are not supposed to take it. Now let's look at socioeconomically disadvantaged individuals. Socioeconomically, we all know about the economic status, and America like to group those middle class, lower level, upper or whatever level class of people, socioeconomically. So this also considered a special population. Disadvantage in the socioeconomic sense are correlated with poor health outcomes, educational levels, income, family, social support, and community safety are factors that can influence health and health outcome. So these are people that don't basically make a lot of income and they are considered socioeconomically low or poor. So the risk factors are individuals of low status, and they are more likely to engage in risky health behaviors such as smoking, alcohol use, recreational drug use, physical inactivity, poor nutrition, and engagement in criminal violence. So socioeconomically, they are considered special population. So these people, you involve the social worker. So when you have a patient that comes to you, some of them will not even want to get out of the hospital. And some of them will also want to fight. They come in and they want to make trouble because they are just aggressive. They are high for some reason. So those people, you involve the social worker to try to help them with healthcare need and services if they can be of help. So you also direct them to the paid clinics so that they try to work out their payment method for them. Now we have the uninsured people. So most of these socioeconomic people are individuals who are uninsured. So the uninsured people too, they can be considered as a low population risk. So these individuals with low income are most at risk of being uninsured. So the socioeconomically low people, they are considered uninsured. Most of them will not have insurance. So there are those that will come to you and they will need help. You just need to guide them through the right process. They contact the social worker and they get the system social support to be able to enroll in Medicaid and Medicare. Now you need to be able to read about Medicaid and Medicare, the health insurance, Part A, Part B. I think I have it captured somewhere in my presentations. I don't remember which one it is, but you need to have an information of what the insurances to are, because NCLEX like to dig into it. So the risk factors is refer to risk factors for socioeconomically disadvantaged individuals and families, healthcare and considerations for uninsured and insured individuals. You refer them to healthcare considerations for the people that take care of disadvantaged people in the society. Now we have the intellectually disabled individuals. Intellectually disabled individuals are at risk for they are at high risk for certain health disorders. Often the disorders go untreated due to atypical symptoms presentation, which leads to secondary health problems later in life. So the intellectually disabled people, so intellectually you are disabled in your thinking, your mind is not thinking right, you tend to be deprived from certain ailments because you may have problem but you don't manifest the symptoms. So nobody tend to understand you. Nobody tend to know what is going on. So they end up getting into complications. So the risk factors are common health conditions that include motor deficit, epilepsy. So those that have the epilepsy, allergies, otitis media, that's the chronic one, the GERD, dysmenorrhea, sleep problems, mental illness, vision and hearing impairment, constipation, and or oral profactors. Clients need to eat quickly, so choking and aspiration presents a safety risk. So some of these people, because their mind is not so straight, you give them food and the person is just rushing the food, everything in the mouth. So you have to give them food and you have to be with them and then coach them and guide them how to follow behavioral stuff so that they don't get choked. Now we have the battered individuals and victims of abuse or neglect. So mostly the healthcare providers are often the first point of contact for victims of abuse or neglect. So on the NCLEX, you see questions that will talk about a child that you meet or a child that presents to you, and then the mother is telling you the child's eye started swelling, and then the child said there was nothing, and you will suspect there's a trauma. Then you assess the child's body and you see bruises somewhere. NCLEX will want to know what you would do. So the healthcare provider or the nurses, you are a point of contact for people with abuse. Usually when you suspect abuse, you report them to the Child Protective Services. So if it's a child presenting to you and there's a problem, you suspect there's a problem, the child says it to you, or the mother is giving you a different complaint and you personally think there's a form of abuse, you call the Child Protective Services. So you don't go call the doctor, okay? Because you're a mandatory reporter of abuse. So the battered individuals, abuse or neglect, abused children or child abuse. Consequences are long-lasting, both impacting initial development and influencing health as individuals. So females are more often affected than men. Situations of abuse or neglect include physical, somatic, psychological, behavioral, sexual, and pregnancy-related effects. So the patient presents to you and said, my husband slapped me and he has been beating me up, and now I have headache, or I have this swelling on my lip, and blah, 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 blah. The first thing you're supposed to do is that's violence. So you're supposed to report. Those are mandatory reporting for you, the nurse, to do. So when NCLEX bring those questions, you know that you're a mandatory reporter of abuse of any kind. If you suspect there's an abuse, you cannot deal with the abuse. It's a legal problem. You have to report it. Okay?
Yeah.
So the risk factors for the abused children is children born from 1 year of age are at risk for maltreatment. The majority are victims of neglect. Maternal socioeconomic status and parental behavioral issues impact child risk. So this one, I think we all will understand that. if you have children in the house and the man and the wife are going through a divorce process psychologically, socioeconomically, before they finish all the processes, if they have little children, it impacts the kids. So it will affect the kids, especially where they are not doing this in harmony. And it's like a fight every day. Who will provide food? Every day, who will carry this child to school? They end up staying home. That's a form of abuse. So if all is not working right between the man and the woman, this is where children mostly get abused in this country. So when they present to you and the child problem is that the child has missed school and the child tells you, I've missed school 2 times this week, and you don't know why, that you ask the child says, mommy refused to send me, or mommy and daddy were quarreling. You suspect abuse and you have to take an action to help that child. So most often social protective services or child protective services, they will have the hospital hold the child. Or even if the mother has the child in the house and something is not right, the first thing they will do is they will, when the police get there, or if another person reports a suspected abuse to the police or 911, they take the child to the hospital straight, because they know the healthcare workers, especially you, the nurse. When you see it, you are a mandatory reporter. So when the child comes, you have to hold the child with you. Don't let family member come in until the child protective services come in to do their own investigation and the police do their own investigation. So when you have a child present to you as a form of abuse, that they're suspecting an abuse, you stop the parent from visiting until everything is sorted out. So when NCLEX bring those questions about abuse, note that you are not supposed to let the family be in contact with the child, so that you don't answer those questions wrong as well.
Excuse me. Concerning this mandatory reporting, are we supposed to report domestic violence or just the vulnerable people in the society, like the elderly and the minors? Are we supposed to also report, for example, a woman, a grown-up married woman who is having issues with her husband? We're supposed to report that one too?
If she comes to you and she says, my husband, I fought with my husband, or I'm pregnant and my husband want me to take out the baby, I refuse, and he beats me up and I'm bruised up. The first question you want to ask, did you report to the police? If she did not report, you have to be the reporter. So you report everything that comes your way. That is a legal issue. You cannot keep it. You can treat the wounds and you get the wounds done. But remember, the woman presented to you is violence or abuse. So we call that domestic violence. So if the woman goes back to the same house, she might be dead. The person might kill her. So one thing is you hold them and then you look for the social worker, or you report to the police first thing. You look for the social worker, get them involved, interdisciplinary team, you get them involved so that they find a place for the lady. If the lady personally don't want to go back to the house because they think it's not safe. Okay?
Okay, thank you.
But listen, another thing is that what you see in the facilities is that the lady will give you all this complaint and tell you whatever is going on. But because they don't want the boyfriend or the husband or whoever is the perpetrator behind the whole thing to get in trouble, they tell you, I don't want to report it. I don't want to do this. On the NCLEX, they are not going to take you into those difficult options. But in case you have seen that done in their facility or wherever you work, that they tell you, I don't want to report it, and they let it go. NCLEX, you are not supposed to. You are supposed to be a mandatory reporter. Okay?
Okay.
Now let's talk about single parenting. So single parenting is a reason that will cause child abuse as well. Mostly this affects women when the men run away. I used to have a friend who says, when I get married and the woman is behaving, I'll just pack my things and run away. I won't come back, and I'll travel to a far country. So Mostly when the men run away, the women become the single parent most often. In as much as it may not be only that, there can be reverse situations where the women will run away and leave the man with the children, which has also happened before. So single parenting can cause child abuse or neglect because it's too much pressure on one parent to deal with it. So we have risk factors. Single parents are at increased risk for cardiovascular events and mental problems. You can imagine having all your children to yourself. When you wake up, you have to send them to school, you have to bring them back from home, you have to go to work. You need financial support to be able to care for them. So all that will put a lot of mental stress on the single parent or the one taking the responsibility for the single parent. Now, healthcare consideration for single parents, you assess, they need access to community organizations that can assist in alleviating such burden and provide needed services such as childcare, food security, health care, including immunization and unemployment. So if you don't have a child care, you have children, you're a single parent, you may need support for this. So when they give you a question that asking you to advise a mother what to do, who is a single parent with children, you are supposed to provide them information about the community or organizations that are supposed to help her get all these services, child care and also unemployment information. So all that information, you should be the one educating the mother. Preventative screening are important in this population due to risk factors and negative effects of stress from single parenting. So I said that already. If you have ever been a parent or if you're a parent, you understand the stress alone, how much more than you've been single through all these years. So we have the foster children. So foster children are children that they take them from their parents due to one or two reasons. Mostly this will affect single parents as well. They will have to pick them from their own parent and give them out to somebody to take care of them. Gertrude, if you are listening to me, foster parents, we may not have foster parents where you come from, but Americans do have a higher standard for foster parenting. And when it comes to child abuse and neglect, they will talk about foster parenting. So as a result of child adversity and trauma, this population is at increased risk for health problems later in life. So if they have to take you from your mother and your father and send you to another parent, it's psychologically traumatizing. Later in life, you might feel it. Sometimes when they are teenagers, they don't feel it. They are fine with that. But later when you realize all this, the need that often go unmet for the children in foster care include physical, mental, behavioral, and dental, because the foster mother can never replace the real mother of the child. So the health risks are some of the children in the foster care may have complex health conditions, including asthma, diabetes, food allergies, seizure disorder, organ transplant, HIV, immunosuppression, renal diseases, congenital heart disease, cystic fibrosis, and a whole lot of health problems. Because you are taking the child from somebody else, the foster people they are people who have gone to register with the state, with the child care services. They register and say, I am volunteering myself to be a foster parent. So if parents A and B and C are not behaving and you take their child, the child care protective services take the children from them. I can take one, or I have registered that my registration, I can take up to 3 kids in my house and I will take care of them. That's what they do. They do the job and they get paid. So foster parents get paid for the job. So you, the nurse, should also understand that the children that are in foster care, they are under the care of the foster parents. They have problems and they are considered a special population. So they are not just any child living with their own mother. This is not their mother. So if I had asthma, I was born with asthma, I was a homeless mother's daughter born and I have asthma, and now I'm with the foster mother. The foster mother may not be able to follow up with all these things because she may not know where my mom started. Healthcare consideration for the foster children. I thought I spoke about it. Community resources are important for population, the provision of health, safety, stability, and permanency. Social workers should be included in the care of foster child to facilitate access. So when they bring those children to you as the nurse, they want to know what you'll be able to do. You have to refer them to the social worker. So when you talk about this special population staff, you want to involve interdisciplinary team. That's where you report in. You report in to the police. You report in to the child protective services. You're directing the patient to a place where the patient can go and apply for food stamp. So it is assured that you, the nurse, should have information on all these things. But for the purpose of the enclaves, you just need to know that when a patient presents to you with a problem, you cannot let them go unanswered. You have to answer them, and your answer should be the one that readily meets their needs right now. So their needs right now is accommodation. So you look for addresses and contact numbers for shelter homes for them to contact. And then you involve social worker at all times. So individuals with mental illness. So we know that mental illness is a form of stigma. So they are considered a special population as well. So the risk factors are cardiovascular disease, metabolic disease, and a whole lot, sexual dysfunction, pregnancy complications, and obesity. So people with mental illness, if you have seen a mentally challenged person, you can bear with me that they do go through all these things. So I'm going to go straight to considerations for the mental health individuals. So healthcare considerations, what do you consider when a patient is a mentally challenged person due to lack of insurance by many mentally challenged individuals? They have a difficult time accessing need and healthcare services, so they don't want to go to the hospital. They don't even have the zeal for that. So mental screening should be completely regularly for all individuals, which allows for prompt and accurate treatment strategies to prevent further health complications and mental breakdown. So mental health disorders, for additional information about this population, you need to give them more information about their problem. So if I am mentally challenged, if I have schizophrenia, I need to know what schizophrenia is, and I need to know what medication I'm supposed to take. So most often those people, they don't follow up on their care. So you look for the next of kin, or you look for the family member who is in charge of the patient. So when you are educating people with mentally disability or mental problems on the enclaves, you want to involve the person's, how do I describe it? The person who is in charge of care for this person, the person's relative who is designated to respond in place of the person. You want to involve them in the care. So you don't give all the discharge instructions to the mentally challenged who will go out and forget, never come back for treatment. So you involve the family members in the care. That's why when you are thinking about all these enclaves, think about it as a daily practice thing. That when I am cared, when your mother is sick, or when my mother is sick and I sent her to the hospital and she's lying on the hospital bed and cannot talk, you would have to talk to me instead. So that's what enclaves will want you to do. But in most cases with enclaves, they will want it to be the healthcare proxy, the one designated to talk in place of me. But if they don't tell you, they don't talk about those healthcare proxy, the legal staff of nursing, and the question is just presenting to you, telling you that the patient came to the hospital with the wife, and now the patient condition have gotten worse. On the enclaves, you are allowed to contact the wife who brought him. They came in agreement, they came in harmony. So she also has to know. She's been waiting for information. So you cannot say you don't see their name, then you won't tell them the patient condition have gotten worse, but the patient brought them. But where there's a healthcare proxy, you want to discuss patient care plans and all those things, you're supposed to dig into the healthcare proxy. The patient will have a next of kin on the file. You are supposed to call that one. So those are always the reliable information you deal with in the patient's information. Now, I'm still talking about the health consideration for these individuals. The most common type of abuse is neglect. Anyway, we know about that. Neglect, they are neglected at all times because it is hard dealing with them. So if I'm a working family and have to stay for them, it's difficult. Now let's talk about the older adults. We have elderly abuse as well. And this one is a concern that makes them a special population. So the most common type of abuse is neglect for the elderly people. There are many health problems that can occur in the older client. There are many health problems that can also occur in this population. So the health problems that occur in this population are Alzheimer's. If you have worked or if you have been to a nursing home, you will know what I'm talking about. We have the Alzheimer's, we have the arthritis, dementia, cancer, depression, diabetes, falls, heart disease, influenza, obesity, oral, dental health hygiene or problems, osteoporosis, pneumonia, poverty, respiratory distress, shingles, substance abuse. So all these things count in elderly abuse. It counts. And these are health problems to consider when you are dealing with the elderly population. So you have all these things. Now let's talk about the military veterans. So these are the people I always ask questions about that I don't know, but I'm yet to see a veteran on my one-to-one meeting. And then I ask why most veterans come back and they are homeless. It's a question in my mind that I keep asking everybody around me. This is not part of NCLEX. It's me who has always been curious because I want to know why a veteran would have gone to fight for the country and come back and they are returned and they are homeless. It's a question mark in my head. I am thinking of making it a research to come up with solutions why they become homeless, because it's like the people I keep asking, nobody answers it right to my liking.
I always ask that questions and I can never get an answer.
Yes, so I think I'm going to pick it as a research one of the days. I'm going to do a research on it, and then I'll come up with a survey as to why they always come back homeless, because it's in my mind too. I keep asking people. Sometimes I feel like somebody should know better. And then I have a colleague who even married one that went crazy, but she too doesn't even have an answer for me. So she came out of the marriage because the guy was not behaving. So military veterans, they are a special population. So this population is at increased risk for injury-related and stress-related health illness. The risk factors, these are the risk factors. They have mental health or behavioral adjustment disorders, which are common to them. They have substance use disorder with tobacco, alcohol, or drug use, which is a risk in this population. They have post-traumatic stress disorder. You can bet me with this particular one that mostly when I see somebody with post-traumatic stress disorder, the first question I ask, as a veteran, have you been in the military before? I'd like to ask that question. They have amputation issues. They have long-term health problems. And some of them, they will keep coming to the hospital and they don't just have a serious problem, but they keep coming and every time they bring up diagnosis for themselves. And some of them become hospital shoppers. They move from hospital to hospital. So it's a problem, and that makes them a special population as well. Considerations for military veterans: you identify and treat mental health disorders, assisting in mitigating suicidal risk. So some of them also have risk for suicide. They will be having suicidal risk. So that's a safety issue. So when we start talking about suicidal in mental health, you start thinking safety. So the use of screening tools in identifying such substance use disorder is helpful. So treatment of post-traumatic stress disorder includes exposure therapy, psychotherapy, and family group therapy as appropriate. Suicide among this population occurs on a daily basis. Veterans Affairs Service can assist in managing some of the health issues experienced by these individuals. That's the veterans. They should be able to help their other people. We have the prisoners. So the environment of a prison can predispose a person to different health conditions, such as tuberculosis. So if you are in a prison, you can be predisposed to several health problems. So if you have never been to jail before, if you get to jail, I haven't too, but But I know people who have been to jail, they tell you the living conditions are poor. You have so many, especially when it came to COVID, when you are in jail and you are in a COVID, and we are in a COVID season where everybody just can come up with anything. So the prisoners, they are accused for rape, and rape is a concern for them. Social determinants for poor health are often present in prisoners. So the risk factors are they are more likely to have asthma, diabetes, hypertension, heart disease, and mental illness. Communicable diseases too are also common, like HIV, hepatitis, and tuberculosis is common in this population. Healthcare considerations, correctional facilities is usually sole provider of healthcare for this population. So we have the correctional facilities, that's the prison services. They have nurses that work as a correctional facility nurse. So in case you see questions that talk about correctional facilities, when you have the prison services, they have the nursing aspect of it. So they have nurses that go to work there. So they are the most the nearest people you refer those people to. So prisoners are supposed to be seen at the correctional health facilities. Unless it's something they cannot be seen there, then they go to acute care hospital for care. So now let's talk about immigration and refugees. So mental health problems are primary issue for this group as a result of torturous events. So you travel from your country, you come to the borderline, or you come to Mexico and Trump is building a long wall and you cannot cross it. and the wall is so tall that you have to be a refugee for several years. And after that, they're even threatened to deport you. You have gone through this asylum process, and it gives them mental torture. So for instance, I had a guy, I read about a guy that had traveled from his country back in Africa, because where he comes from, they don't allow gay people. So he's scared for his life. So he had a visa, ran to Canada. I think he ran to Canada border and about to enter US. And then they caught him there, they stopped him, and they are threatening to deport him back. And he's crying because he's crying for his life. So because of that mental torture, he's thinking that when he go back, he will get killed. So this population, their other challenge is how to speak English. So some of them, if you have seen them in the news, especially last year when they were doing the campaign for politics, you see them that they cannot even speak the English, and they are in these refugee camps. They're keeping them and they're camping them for some 1 or 2 reasons before they screen them and allow them. And even when they get into this country, they still don't have the paper to work and make ends meet. So it's a challenge, and this poses them as a special population. The barriers is acculturation to the US, how to get used to the US system. They include the eating habits, the dieting, and you are restricted to your environment. So you don't even have the opportunity to move all around, you are restricted. So other conditions that can result from the process of migration include tuberculosis, hepatitis, influenza, vector-borne diseases, Middle East respiratory syndrome, coronavirus. All these things can result from migration. If you remember how the COVID all started, they said it started in India, when China, when people traveled, and it kept traveling through the world. As to whether it's the corona that entered the planes or it's just human beings, nobody could actually tell. So individuals with chronic illness. So I don't know if any of you have a medical problem, but people who have chronic illness, like kidney diseases that are chronic, high blood pressure that are difficult to manage, diabetes that are very like uncontrolled. Those are chronic diseases that are hard to manage. So they stigmatized. They feel worried at all times. Some of them end up being depressed. Some of them, they have issues with insurance. Those that have to stay on dialysis for the rest of their life. And then insurance is cutting them off, and they know they cannot get treatment. Psychologically, mentally, physically, psychosocially, they are impacted. So these people become a special population because they have chronic illnesses, they need support systems, and the healthcare system is not supporting them enough. Or family, back in the family, they don't have anybody to stay with you. Since you have become disabled, you are chronically ill, you can no longer move around, you need a specific diet, you can no longer drive the car to go and buy, then you are left alone. So this one make them a special population. So they are at risk for several health problems, including mental illnesses. So that's the chronic ill people. They're a special population as well. So the risk factors is individuals with one chronic illness are at risk for developing multiple of them. So you end up developing multiple of them. If you just had like a kidney problem, you end up developing depression. You end up developing mental problems, schizoaffective, mood disorders, because you have been left alone. So they have non-modifier, they have the modifiable factors, which include an unhealthy diet, physical activities, and tobacco use. So they have the modified, these are behaviors that can be modified if they get the necessary assistance they need. So they have the non-modifiable ones as well. And that one is the age and the genetics. You cannot modify that one. So they put up behaviors that will help them get away their pain. I heard about this song that a man was owing somebody and they now have money and his children keep asking of school fees. So he decided to go and drink so that he'll forget his problems. So it's a modifiable factor if you do that. If you have so many problems, you go and drink just to become drunk and then forget your problems. It's a modifiable behavior. But those who cannot modify is your age and your genetic makeup. You can't modify that one. Now, special population groups. We have the racial and ethnic. I think I spoke about this one. So these are the people I just grouped. These are the people I spoke about. I spoke about the racial and ethnic minorities. That's why I started with the African Americans, the Hawaiians, and all that. Then I spoke about the gay, lesbians, the queer, and the questioning individual. The homeless, we spoke about them, socioeconomically disadvantaged people and their families. And intellectually disabled people. We spoke about the battered individual, victims of abuse and neglect. We spoke about foster children, older adults, military veterans, prisoners, immigrants, and individuals with chronic illness. Then this is a note for you. I said special considerations, special population needs assessment tool. Not all questions listed. Okay, so I have the assessment tools behind this for all these populations. It's like if you go to assess them, I will just run quick over it and then we go for break. When we come back, I'm going to start the renal system. I'll just talk about the anatomy and we close for today. So we have this background screening questions. So if you are faced with a patient from any of these populations we spoke about, there are specific questions you should be asking them. This is what NCLEX will want you to know, so that when I am a military veteran that I come to you and I am the patient, NCLEX present to you such patients, you should know their assessment tool, the assessment questions you are supposed to ask. So these are a lot of questions that I think you guys can just read it, or if you want, I can make a video of it and then send it out. But the general background questions, I can talk about that before you go into the individual groupings of the people. So if I am a foster child, there are questions you should be screening me for. If I am a homeless individual, if I am a victim of abuse or neglect, there are questions you should be concerned about. These are specific for the NCLEX. So if NCLEX is bringing questions on those things, and they want you to be specific, if they don't give you a limit, then you can use the general background questions. So the general background questions are pretty straightforward. So the individual questionnaires too will be straightforward. Are you comfortable talking to me? So you present with the patient, that's the question you ask. What name would you like us to use to address you? So I spoke about this one too. Do you feel you are able to adequately answer questions regarding your health? What is your age? Is that a specific gender? Is there a specific gender in which you identify yourself with? So you want to be a man or a woman? Yes, no. What is your ethnicity? What is your primary language spoken? You want to make sure you understand the language the person is going to speak. That's your initial encounter with the person. So these are simple, straightforward daily communication that you will give to people. That's what NCLEX is asking you to know. But these are general ones. But if I am a foster child, there are questions that you be asking me that are specific to a foster child. So when you have a question on the NCLEX and the child is a foster child, your mind should already have directed you on things that are specific to a foster child care. Do you understand and speak English? In what language do you wish to communicate? Do you need an interpreter? Do you have any cultural, religious, spiritual preference you would like us to consider in your plan of care? So all those things are captured in the patient plan of care. So these are pretty straightforward. Describe your eating habits or eating pattern in 24 hours. Do you exercise? What do you do and how often? Do you use any remedies when you are sick? What do you do when you are sick? So trust me, these are straightforward questions. I don't need to talk too much about it. There are questions that you should know. When you get things like this, you should be able to tackle it. I would rather prefer you go over this one is asking about the living situations, but it's still part of the general questionnaires you ask the patient. So these are further questions on financial issues and access to resources. You want to know if they have anybody in the house to support them, if they have a job, if you have any income, any source of income that is sustaining you, and any community support that you know their numbers and you are able to contact them. Then you also want to talk about their insurance. So general assessment, you want to find out, do you have health insurance? So this is basically like registering a patient who is from a special population or any other patient. So further questions related to abuse. When you look at a patient triad, they will always ask these questions. Are there any domestic violence, any history of abuse, any depression, any anxiety? Do you have any of that? So you're screening the person to know more about the person. So if the patient comes to you and they say it's a homeless person and you are the nurse, you are asking all these questions. Do you have insurance? Do you have this? Do you have anybody at home? Where do you live? What is your address? How do you want me to address you? What is your sex? What is your gender, your age? So further questions based on racial background. So you want to ask these questions because if I am an African American, you have to ask me questions to know. So if I am African American, you already know the health problems, high blood pressure, and they have 50% of their elderly affected with chronic illnesses. So those are the things. So now further questions that are based on gender and sexual orientation. So in the initial screening, when you're screening the patient tells you, I want to be identified, I'm a gay. Just put gay for me. I just put gay for me, I'm a gay. I don't engage in sexual activities with females, so I'm a gay. So that's where you now go specific and deal with the further assessment for a gay person. You understand? Or you assess a 14-year-old in a foster care and the patient tells you, I have mental issues. Then you now go on mental specific assessments. The patient tells you, I'm a veteran. Then when you finish the general questionnaires, then you now dig more about the veteran activities. What did you do? Which country and how long? And you ask all these living situations. So you know that veterans will end up homeless. They may be drug addicts. So you ask them, do you use drugs? Do you do this? And then you go specific. Somebody tells you, I'm an immigrant. So you start asking, what is your immigrational problem? What is your medical, mental, and physical problems? So you go specific in that aspect. Now, somebody tells you I have chronic illnesses. I have, I'm talking about dialysis today because we are going to the renal system. So the person tells you I have chronic illnesses. Then you start going, do you have access to primary healthcare provider? Because every chronic problem would need a care provider. So you start asking them further questions based on that. So in summary, is there anything else that you would like to share regarding your ability to maintain your health or any other issue? That's what you just want to ask them. Is there anything you would like regarding your ability to maintain your own health or any other concern That's what I will also ask you. Any question?
Go.
Do we have any question? Besides that, we have finished that topic. That's the end.
No, I don't have any.
So if we don't have any question, listen, we can go for a break. And then when we come back, we try to tackle our renal system quick. We'll do the anatomical component of it so that when we come the next time, we'll finish it and we are done. I don't want to stay long in topics. It's like, does anybody have a question? Gertrude, you with us? Gertrude? So I'm going to stop the sharing. No one has a question?
No, I don't have it.
Okay, so we'll come back 45, okay?
45, okay.
Yeah, we're going
All
to
right,
do
thank you.
45.
Oh,
So I see you.
okay, station.